Now,
Okay, so good evening, everybody. Welcome to today's webinar brought to you by the Orthopaedic Research and Education Foundation India through OrthoTV. And today we have Dr. Warid Altaf from Sancheti Hospital. And to give a brief introduction for him, I would hand it over to Dr. Janki Sharan Bhadani. Over to you, Janki.
Thank you very much, sir. So, good evening, everyone. Dr. Warid Altaf is upper limb surgeon in Sancheti Hospital, Pune. He is a gold medalist in DNB. Uh, so I think without any delay, I'll hand over to Warid.
Yes, thank you, Dr. Janki, and thank you so much, Dr. John, from joining all the way from the United States. So I'm very glad, and I've always been, fond of teaching, and I remember from my DNB days, and even in the institute like Sancheti I'm working in, we have residents, and I'm really fond of teaching. And my areas of interest is the hand and upper limb surgery, basically. So I'll be talking on. The examination of ideal examination of the wrist and hand, basically, because most of the times, even now, our exams are going on right now. I think it was the second day of the postgraduates MS exam which was happening today, and we have always seen that many times, we have seen students fumbling and making mistakes of examining basic pathologies in the hand. That may be any tumor, or that can be any sort of nerve injury or deformity. And I hope after this lecture that I'll be able to make things easier and clearer to all the residents who are watching us here. So we can make it interactive also in the middle. If we'll go slow, and if anybody is having any doubt or anything, we can even have a one-on-one discussion on that. Or of course, at the end of the lecture, we are going to have some time for that. So we all of us know that a hand case is going to be a short case in your exam. In a postgraduate, there's a long case. There are two short cases. So a hand case is going to be a short case, but we are having two short cases for the MS students. So for DNB also, I think it's the same, but there's a very high probability that you'll get a case related to a hand, because there are many area of diagnosis and pathologies which are there. So the probable cases which you can get is a malunited distal and radius, which is commonly neglected, and there's a deformity, and that is one case which is kept as a short case. Any tumors or cyst around the wrist joint, a giant cell tumor or any enchondroma, a big ganglion cyst, a compound palmar ganglion. There are many tumors which happen in and around the wrist joint. Then a rheumatoid hand, is again a common. They may have a swan neck deformity, a boutonniere deformity, ulnar drift, or von Jackson syndrome, or extensor rupture, tendon ruptures, and all those things. So post-traumatic arthritis is another thing which we see commonly. A neglected intraarticular fracture of the wrist, or again post-infection. Chronic nerve compressions are also commonly seen. Maybe that is a carpal tunnel syndrome, or a chronic ulnar nerve palsy like a claw hand. A radial nerve palsy again is a wrist drop. So tendon injury is neglected, or nerve injury. So there are many possibilities of having any of these as a short case, which can be and even in elbow you can see a post-traumatic stiff elbow, cubitus varus valgus deformities, etc. So just remember one thing, that there are three basic questions which are going to be asked to you when you present a short case. It's not going to be as a long case. You have a long history to present, and then coming on to examinations, and then diagnosis and investigations and treatment. But here, the first thing what most likely the examiner is going to ask you is, what is your diagnosis? So you have to be ready with your diagnosis. You
ठीक आहे.
whatever time
मी
you
याचा
get,
आता वाचायला सुरू करणार होतो आपल्या केस
whatever
उद्या आता
time.
परवाचं सनदने काही सांगितलंच नाही अजून.
Janki, just mute everyone else.
then you have to be ready with your diagnosis, because the moment you enter, the examiner is probably going to tell you that what is your diagnosis. Once you've said your diagnosis has to be crisp, to the point, not like a long case, a long diagnosis. It has to be very precise. That is how the most of the examiners like. And then the second, if they're happy with your diagnosis, the next question what you will get is what are the points in favor of your diagnosis. That is one, two, three, four, five. For example, if you're a case of a non-union, you have to say that, you may say begin with a history quick, that there was a history of trauma, and then, there is an shortening, there's an abnormal mobility in two planes, there is loss of transmitted movements, there's deformity. You have to tell points in favor of that particular diagnosis. If the examiner is happy with that, the next question is going to be what will you do? And that's going to be, I mean, then you go on, and if you want to order investigations, you can say that I would like to do an X-ray, which most of the cases we have to do an X-ray, and then you are through that case. If it goes smoothly in this order, you are through in that case, and it will literally take 5 minutes, 5 to 10 minutes. Your short case is over, and that is how your aim should be. That is what your target should be. To smoothly go ahead through the short case, not get stuck in any of the points, like not mostly getting stuck with the diagnosis, and you have to be very crisp. So how do we do that? So I'll try to make things easier. Okay, so the moment you enter the room where you have to examine for your short case, you start examining the patient. At the same time, you have to speak with the patient, develop that rapport quickly, and try to get the history. Although history is not important in short case, so you don't have to say the history in detail, but the history will give you a lot of things which will help you to get into your diagnosis. And that is basically, first important history. What you're going to ask is, was there history of trauma? And if there's a history of trauma, in that case, it's like, was it a blunt trauma, or it was a laceration, or it was a penetrating kind of a wound? Second important thing you can ask is whether there's numbness or tingling, whether there's a diurnal variation of the numbness and tingling as well, whether there is a pain, what kind of a pain it's there, if there's a swelling around the wrist, and what is the onset, duration, and progression of that. Because all of these tells us a lot of things. Trauma will definitely tell you whether you're going to look for some neglect if there's a tendon injury, or was there is some fracture, and how it has proceeded ahead. And then swelling, if it is shorter duration of history and if there's a large swelling, then you probably are going to think it's an aggressive kind of a lesion. If it is there since many years, you probably may not take it that seriously. That's because it's present since long time. So all this history is very, very important. And the second important thing, we come to the examination. And in examination, we all know the steps is inspection, palpation, movements, measurements, special tests. So in orthopedics, we know everywhere this holds true. And this is how we are going to follow in the hand and wrist as well. And believe me that inspection is one of the most important thing in hand and wrist, which tells you most of the time what the diagnosis is. So the moment you're talking to the patient, you must have done with your inspection already. Since you're asking him what was the history, when was the trauma, when is the numbness from, by the end of that, your inspection should be complete, because you have to do that simultaneously. So develop the habit of examining a patient, talking to the patient, and also inspecting at the same time. And because inspection will give you many things, I'll come to that. Is that, see, you can see any sort of deformity, wasting, scars, discoloration, trophic changes, and always compare it to the other hand. Whenever you are examining a patient of hand and wrist, the patient should be across the table in front of you, and you should comfortable, because you may need to rest his elbow on the table and then examine the movements of the wrist. So make sure that the patient is comfortable, and you can see both the hands together. If you look at this particular photograph, what do you see? Then whenever the patient is trying to flex, there is a deviation in the finger, in the ring finger. And in the second image, you see when the patient is trying to flex, there's no flexion of the little finger. And this is again a spot diagnosis, or this is again a spot diagnosis. So in the first image, there is some sort of deformity in the ring finger which you can see. So probably it is maybe a malunion of the proximal phalanx or the metacarpal, which is probably in a rotational deformity. And when the patient is trying to flex and there's some rotation, scissoring at the tip of the finger. And when you see the second image, there is absence of flexion in the little finger. That means both the flexor digitorum superficialis and profundus are lacerated. And that is why it is absent. This is a classical of ulnar claw hand. There's claw hyperextension of the metacarpophalangeal joint, inflection of the interphalangeal joint. And this is a case when there's a chronic thenar wasting. You can see this. This is a chronic low or maybe a high median nerve palsy. So these four images, if you see, you can in a flash of a second on inspection, you should be able to diagnose these. You don't need to touch the patient for this. When the moment you see, you know that okay, this probably is a median nerve palsy or ulnar claw hand or a tendon injury or a malunion. Normally, when we flex the wrist and all the fingertips, are parallel. That is important. So again, for example, if you see this patient has an extension of the finger. You see this, it looks normal, and the moment the patient uh, flexes the hand, and then you can see again there is a mal rotation of the ring finger. So that is again, this is on inspection. You can see the deformities like this. This is again a picture of a rheumatoid hand. You can see a swan neck deformity on the left hand side. I'm talking about you can see a swan neck deformity here, and you can see maybe a botanier deformity in the little finger. And this again is a deformity at the distal phalanx level, and this is probably a mallet finger. And you can see there's the fingertip is dropped. And this again is a very typical cord-like flexor tendon you can see here, and this is basically a Dupuytren's contracture. So they have very hard nodules, and you can easily see it on inspection most of the time. So again, on inspection you can see a number of things: rheumatoid arthritis, mallet finger, Dupuytren's contracture. So make sure you don't miss things on inspection. Apart from this, atrophic changes or wasting on the first web space on the dorsal side is an ulnar nerve sign of an ulnar nerve palsy. So now you can go ahead and touch the patient and start palpation. Palpation is again very important. You start from one side and you complete and go to the other side. I think that you should not miss anything. What I want is point out in palpation. Important thing is because in the wrist there are many bones there are which are involved. See, if you see the radial side, you see the radial side, at the lower end of the radius, the anatomical snuff box, the first CMC joint, the scaphoid is there. So on the radial side, there are many things. And the moment the tenderness you elicit, you have to be very specific at which point there is tenderness, because a few millimeters changes your diagnosis, literally. A decurvent stenosynovitis is right on the ulnar styloid, radial styloid. And you just ulnar deviate and you try to palpate, there's a lot of pain. That is a decurvent stenosynovitis. The moment you go a little distal half a centimeter and you try to palpate, and that's the scaphoid. And that is probably the scaphoid non-union, which is giving pain when you're palpating there. And the moment you go a little more distal, that is the first CMC joint arthritis. And that pain is there. The moment you go a little proximal to the decurvent point, that is a superficial radial nerve. There can be an entrapment of superficial radial nerve there. So a four diagnosis is here. So you have to be very specific on palpation, that where you are palpating, where is the pain, and elicit that in that particular patient. And all these conditions are common. It's not that they are uncommon, they are common conditions, and you should be very sure. There have been instances that patients have been treating for CMC and he has a scaphoid non-union or the otherwise. So make sure not to miss certain things. Similarly, it goes from when you go in the dorsal aspect of the wrist, there are many bony things there. You need to palpate the Lister's tubercle and then scaphoid, scapholunate interval, and then you go to the lunate for Kinbox disease, or a little more ulnar is the ulnar impaction syndrome, where you can get tenderness on, and then you go to the ulnar snuff box where you get the TFCC tenderness, and then you go on the volar side. So start from one side, make sure you don't miss. You can Radial styloid, go to scaphoid, first CMC joint. Lunate, Lister's tubercle. Ulnar styloid, so TFCC. Hook of the hamate also. Guyon's canal. So you can circumferentially start from one side and make sure that you're not missing any of these. Okay, central wrist pain, very important. I told you about radial styloid, a central wrist, skin box disease. Go flex the wrist, try to palpate on the lunate. It will be very painful. It's very important to diagnose them early, because if you catch them in stage one, you can really change the outcome of the disease. And that is very clinical examination is important, because most of the time the X-rays are normal. So you should know the background, that it's more common when there is a negative ulnar variance. So if you compare your X-ray has a negative variance, tenderness is there, you can order an MRI in early stages to pick it up and things like that. So that is how you become better clinicians. You don't miss out things. So palpate the hamate, look for temperature, of course, look for sensations. Very important. I think all of you must be knowing the anatomical, landmarks about the sensation, where the radial nerve sensations are to be seen, where the median nerve is seen, and where the little finger is for the ulnar nerve. So all the autonomous zones of sensation actually are very important. Look for movements, dorsiflexion, plantar flexion, ulnar deviation, radial deviation, and even rotations, pronation, and supination. Thumb movements are very important. Most of the students we still, see that they don't, they fumble in both basically in thumb movements when they are talking. Where is flexion, extension? So when we are talking of flexion and extension, the flexion and extension is in plane with the palm. That is this flexion, extension, and adduction. Abduction is 90 degree. Abduction 90 degree to this. So up, this up movement is abduction. This is adduction. Abduction, adduction. Flexion, extension is in plane with the palm. So important. These are important because you got to check for a position. You have to check for median nerve function for when you are checking for the low median nerve palsy. Check for the grip strength, and pinch strength is again very important. Range of motion is also, you should know what is the normal range of motion at various joints, like metacarpophalangeal is really 90 degree, and the PIP joint is more than 90 degrees, it's around 110 degrees. And DIP is again less, it's around 50 to 60 degrees. Movements of thumb, very important. They are going to ask you in examination. And then you go on and go to the special test. In special tests, I think, see, whenever you get any case related to hand, you will be asked about muscle testing. You have to be ready, you have to be thorough about the muscle testing, because even if you get a case which is not non-neurological, it may not be a neurological case, but still, and some of the examiner would like to, ask you, how do you test this muscle? How do you test that muscle? That's something which has to be known by each and every one of you. So what is being tested here? When you are stabilizing all the other digits and ask the patient to flex one of the digit, that is, you are testing the flexor digitorum superficialis. Okay, so that has to be clear. You are checking. Similarly, for the other finger, you can stabilize the other digit and tell the patient to flex that particular finger, that is flex the digitorum superficialis. And when you are stabilizing the middle phalanx, and then asking the patient to flex the distal interphalangeal joint, that is when you are checking the flexor digitorum profundus. This is again very important. Now coming on to this is a snuff box. You can see the black marker which is placed, which is on the radial border of the snuff box, and this is the ulnar boundary of the snuff box. So this is again very, very important. So this is the first compartment. The one which I told you about, the decurvent stenosynovitis, is abductor pollicis longus and extensor pollicis brevis. All of you should know the six wrist compartments, extensor compartments. The first compartment is what is being shown now, which is the radial side of the anatomical snuff box, and that is the abductor pollicis longus and extensor pollicis brevis. And the moment you go to the ulnar side of this, then you go to this is what is being checked here right now is wrist extension against resistance, and you are palpating on some muscle or tendon, which is extensor carpi radialis longus and brevis. That is the second compartment. right? These are the wrist extensors. Always remember, whenever you are checking any muscle in the body, one hand should be on that muscle, palpating to seeing the contraction of that muscle, which is very important. Third is the extensor. This is the extensor digitorum, which what is being checked right now. And this is the third compartment, which is extensor pollicis longus, which is on the ulnar side of the snuff box. And this is the fifth compartment, which is extensor carpi ulnaris, and sixth is extensor carpi ulnaris. And opposition is the function of the median nerve, which is going to be checked, and always check for the muscle which is here. Whenever you're checking for opposition, make sure you see the contraction of this, the thinner eminence here happening. So this is flexor pollicis longus, long flexor of the thumb. You stabilize the proximal phalanx and tell the patient to flex the distal phalanx. Coming on to the specific examination, this is in general, I was telling you about the muscle testing which is seen in the hand. Now, if you, that is usually the extrinsic muscles which we have checked. Extrinsic muscles, important question again asked to most of the students is what I've seen is what are the extrinsic muscles or what are the intrinsic muscles? The extrinsic muscles of the hand are those muscles which originate away from the hand and are inserted in the hand. That means the long flexors and extensors which we have just examined. And intrinsic muscles of the hand are those muscles which are originating in the hand and they are inserting in the hand as well. So all the small muscles of the hand, they are intrinsic muscles of the hand. And ulnar nerve is one of the nerve which is supplying the intrinsic muscles of the hand. So this is a complete claw hand. You can see patient is having a typical hyperextension at the metacarpophalangeal joint and there's a flexion at the interphalangeal joints. This is a complete claw hand. What you can see here, you can see clearly there's a wasting of the muscles of the first web space, and that is a typical sign of an ulnar nerve palsy. In most of the chronic cases, the patient will just come in with a deformity like a claw hand like this, and it's very easy to identify that. Prominent sign, a very important sign, you have to tell the patient, to check for the pinch strength basically. While pulling, you can put a card, it's also known as a card test, or a book test rather. And basically, this test checks three muscles. What is important is you need to know what is the pathophysiology, what is the basis behind this test. And it checks three muscles, that is adductor pollicis, first dorsal interossei, and flexor pollicis longus. Two are intrinsic muscles which are supplied by the ulnar nerve, and one is an extrinsic muscle which is the flexor pollicis longus which is supplied by the median nerve. So when there is a paralysis of the intrinsics which is supplied by the ulnar nerve, the patient, whenever he's trying to hold that card or piece of paper or book, uh, patient is not able to, and the moment he tries to use his flexor pollicis longus, that is the flexion of the thumb for that. So that is how basically you get to know that there is a ulnar nerve palsy, and then that is known as a Froment sign. And in chronic cases, you can very well see that there's a good amount of wasting seen, and then there is also a hyperextension kind of a deformity here, which is also known as they're not able to make an okay sign. I'll come to that in median nerve palsy. So this adductor pollicis is basically which is paralyzed here, and again this is hyperextension and flexion deformity. This is again a Froment sign. So again, coming to the interossei now, the palmar interossei, adduct, and the dorsal interossei, abduct, all of us know that. So checking of this is again very important. Abductor digiti minimi is a very strong muscle. You have to tell the patient to abduct against the resistance, and here is the muscle where you can palpate this muscle. It is a very strong muscle, and you can see a very strong force can be given because while pushing this. So check for that again for an ulnar nerve palsy. Unopposed pull, there's something in this finger escape sign. You can call it a little finger escape sign. This is also one of the sign of the ulnar nerve palsy. First dorsal interosseous, again check for the abduction of the index finger, and that is the first dorsal. So those are the basic tests you do for checking of the ulnar nerve. Now coming on to the median nerve. Median nerve is basically supplies, it's a muscle of the forearm. So it supplies all the long flexors. And you can see that is the normal side, and you can very well make out here that there is wasting of the this thing here. There's a first web space is wasting, and patient is trying to flex the IP joint of the thumb and not abduct the thumb. Basically, that is a pen test, and that is a very old test, and that has been very well documented. Again, a pointing index is another sign of a ulnar nerve pulse. So, a median nerve, ulnar nerve, sensory supply. We all of us know where is it, and how to examine it. So coming to the other tests, important some important test in hand and wrist is the one which is showing first one is a Phalen's test. The second one is the Durkin's test and Tinel sign. All three tests are the tests which we do in patients with carpal tunnel syndrome. Usually for 30 seconds you need to flex the wrist, hyperflexion, and then they will have definitely signs of paresthesia, tingling, or numbness. Who those patients who have severe symptoms usually they end up having this clinical test as positive. Tinels is Durkin's is supposed to be a very specific and more sensitive test than Phalen's and Tinels also, yeah, and it has been very well proven. Now, 2 point discrimination along the fingertips. For decurrent stenosynovitis, I think I told you earlier, a Finkelstein test is usually very painful. It should not be done in patients who have acute pain. And there's something known as a Watts test, that is wrist hyperflexion and thumb abduction test, which is a very specific test and relatively much painless test to diagnose for the decurrent stenosynovitis. Foveal sign is important. The ulnar snuff box tenderness. I was telling you earlier that make the patient comfortable. Let his elbow rest on the table, and see how painful it is. You can see the wincing on the face of the patient the moment you palpate on that in that ulnar snuff box. You have to make the patient comfortable. That is very important, and you have to gently palpate on that, and then that's it's a very specific test for DFCC injuries. Piano key sign is something which is when there is a DRUJ injury, which may include, of course, the TFCC tear, and also some amount of DRUJ is involved, and you can get a ballotment, which is very much seen clinically, and that is known as a piano key sign. And I'm sure all of you must be knowing this, what is this particular test. And when you flex the wrist, you are able to extend the finger, but when you're extending the wrist, you are not able to extend the fingers. So in flexion, the finger are getting fully extended, and the moment the wrist is extended, there is a stuff, you are not able to get the finger extension. You can see a scar around the elbow here. I'm sure all of you know that. So this is known as the Volkmann sign, and that is the constant length phenomena which happens when the forearm muscles get contracted and shortened. Bunnell's test for intrinsic tightness. You flex the wrist, flex the IP joint, and then try to extend the metacarpophalangeal joint. You should know, I think maybe this may not be asked to you in your exam postgraduate, but anybody of you who knows this it's always better. So swelling around the wrist, like I mentioned earlier, we'll come to this quickly, is I think whenever you get any tumor, maybe that is in the hand or wrist or upper limb or lower limb, the most important thing what you should be able to diagnose to know is whether the swelling is benign or malignant. If I am the examiner, if you justify that you're diagnosing a swelling clinically, it's benign or malignant, you'll pass in that case definitely, because That is what is expected from you. And to know why you are saying this swelling is a benign swelling or it's a malignant swelling. So if you see these two pictures images, they look to be a benign swelling, on inspection, because there are no dilated veins, doesn't look angry, doesn't look any cellulitis, and the swelling which is associated, which look angry, mostly we consider them as a malignant swelling. And similarly, if you see this swelling, there are dilated veins, there is some induration, there is some deformity in the little finger. So this, if we look at this finger, this swelling may be a malignant swelling. You have to be careful about the swelling like these. When you see the redness, when you see dilated veins, versus when you see this swelling like this looks like benign swelling. So what are the characteristics of each? That is very important. You should know that. This is a classical picture of a giant cell tumor. It looks like a giant cell tumor. There is a shiny skin. It's a locally aggressive tumor. Lower end radius is one of the commonest sites. So you should know what are the features of what particular tumor, and you should know clinically how to diagnose them. This is again looks like a benign tumor. It is for the giant cell tumor of the ulna. Sometimes tumors have no rules. Basically, they can present like anything. So of course, your clinical diagnosis is of course very very important, but it has to be supported by investigations. And this particular case looked like a benign swelling, but it turned out to be an osteogenic sarcoma. So you have to be very careful. This particular swelling, again, this was a very highly malignant tumor. It was an osteosarcoma of the proximal phalanx, on which a reamputation had to be done. So important, why I am telling you all this is, in your clinical practice, you should know what is benign, what is malignant. This again, the classical pedunculated osteochondroma. You don't need really MRIs for these. This is a clinical and X-ray diagnosis, and you can very well, excise extraperiosteal resection. A diffuse swelling, if there is in the hand, that means, one of the commonest diagnosis will be infection. There can be cellulitis, there can be abscess, and that was but drained. And this again, this is a classical picture. You should, of course, clinically be able to diagnose this, but I've put an MRI here, a dumbbell-shaped swelling going across the wrist. I'm sure many of you must be knowing this, and this is a typical picture of a compound Palmar ganglion, compound which goes from the wrist crosses the carpal tunnel and goes across the wrist. A dumbbell-shaped swelling, mostly it is tubercular or it can be a rheumatoid inflammatory lesion. So that is, it needs excision when it is, progressive. So the important key points are, precise examination will give you a better findings rather than X-rays and MRIs. I'm telling you honestly, I've been practicing hand and upper limb surgery since last 10 years, and nothing can give a better diagnosis than a clinical diagnosis. Of course, you need to do X-rays. Of course, you need to do MRIs whenever it's required. But that has to support your clinical diagnosis, what is in your mind. You can't order investigations to look for a diagnosis. You have to order investigation to confirm what you have been already thinking in that particular patient. Because MRI can give you any kind of a report, and you will get confused and your patient will get confused what is happening. TFCC especially happening, there are a lot of studies, even we are doing one, that MRI and arthroscopic findings in TFCC injuries. Most of the MRIs with patients come with have reported as TFCC complex tear, complete tear, partial tear, or any sort of tear, and that patient is absolutely not having any ulnar sided wrist pain. And the pain is on the radial side, MRI is showing ulnar sided wrist pain. So it will take some time to get to get all this streamlined, but what remains important is your clinical examination. Ultimately, it is your patient. You have to treat that patient, and you have to justify and do justice to what you've been taught and teaching. Follow the sequence of examination to avoid important missing important findings. Palpation is very important. Thank you. I think
Great, Warid. That was
we have
excellent.
enough time for
Yeah, we have time for questions, so we'll open it to the
the
delegates for questions.
to discuss
Thank you very
something.
much, Warid. That was excellent.
Thank you, sir.
Yes.
So questions.
So yeah, while we are waiting for questions, just one thing, you have shown so many things in palpation.
Yes,
So it's in very close space. So how to like when they are telling about the diagnosis,
right.
which one to keep first and how, because that is little confusing for the
Postgraduate.
postgraduates to explain. Yeah.
Yes, I think you're right. I think it's it is a matter of habit, what I can say at the end of the day. It is, for example, we've been in postgraduates most of the times. We've been taught for hip examinations, and a lot of thing about hip examination, Thomas's test to from adduction, abduction, deformity, etc., etc. So that pattern is there. And I think in hand, we should always follow some pattern and, make it in our mind that whenever we are examining any patient, we should follow that sequence. I think then it becomes very easy. And there are not many diagnoses actually. If for residents, especially if we are, if residents have to appear in exam and pass for the exam, and then go into the practice. There are on palpation, because you specifically mentioned that on the radial side there are 3 to 4 diagnoses. One is decord veins, second is scaphoid, which can be a non-union, and third is CMC joint arthritis. And when you go to the dorsal central side, there is Kienbock's disease. And when you go to the ulnar side, there is TFCC injury. And when you go to the volar side, there's a hook of Hammett. Sometimes there can be a non-union or a nerve entrapment there. So not really much. And again, you go on the volar side or here, there is a scaphoid again, which you distal pole you can palpate. So you have to keep all these differentials in your mind. Of course, relate it with your clinical history, what patient tells you, and then I'm sure it is not very difficult. It's pretty easy to diagnose and memorize this.
So I think many things will be pretty obvious, but there'll always be situations where you're not quite sure, and
Right.
there you go by your findings. So I mean, you rule out things by your clinical examination. I think that is really important, and Warid has really emphasized on that,
Yes,
that
yes.
go by your clinical examination before you rely on investigations.
What we
Uh,
are seeing these days in our clinics is most of the patients are coming with the investigation,
Yeah, that's right.
with MRIs and 2 MRIs and CT scans, and then they are like, we have a TFCC tear, we want treatment for that. Then when you examine that patient, and he's absolutely not having any symptoms in that region, so it is difficult to convince those patients first. And but then if you explain them, if you tell them that these are the things, you don't have tenderness there, you may have some other issue, and then they, of course, they do understand. So I think in this is an area where there is a lot of discrepancy between the MRI findings and the actual diagnosis in the wrist.
So there was a question from someone asking you to repeat examination of 3 nerves by the thumb movement only.
Oh, okay. So yeah, okay. So I think probably there is something what we were taught was an okay sign. There is a flexion of the interphalangeal joint of the thumb, and you should be able to make this round. I think if it goes into like this, then there is an anterior introitious nerve or a median nerve palsy. So flexion of the thumb, flexion of the index finger, and fanning of extension of all other fingers. I think this is by one action if you want to check all the 3 nerves. And also wrist should be in extension while doing this, because you have to check the radial nerve is the one which extends the wrist.
Yeah. And there's another one of how to summarize any nerve palsy case.
Okay, okay. So, like I told you in the beginning, that your diagnosis has to be it has to be crisp. It cannot be a long diagnosis, and then examiner also is wondering what is happening. So you can in a nerve palsy case, especially what you should not miss is because I've seen yesterday I was attending our MS exam. So we have seen that the duration of the nerve injury is important because, for example, it's a wrist drop. It's a high radial nerve palsy. So in a radial nerve palsy, please mention it's very high, high or low. If there's a wrist drop, that means it's high. If the triceps is also involved, that goes to very high. Or if it is only posterior interosseous nerve, it is low. So mention that whether it's high, low, very high. Similar for the ulnar nerve, it is high or low, and median nerve, whether it's high or low. For a nerve palsy, it has to be mentioned. Second is you have to mention the duration because that tells us if it is 5 years old, things change a lot. If it is 2 months, 3 months, then your treatment changes accordingly. You have to order investigations accordingly. So duration has to come there, and whether it's recovering or it's not recovering, that is an important thing which is expected from you. And I think these are the three important things. For example, it's a 4 months old case of a high radial nerve palsy not recovering in a this year old gentleman, maybe associated with a fracture or with not a fracture. You mention that, or what is the status of that injury. 3 to 4 things I think you should not miss out on that.
I think, Subhanshu, that what when you told that posterior intraosseous nerve, that means it is finger drop, right?
Right.
Only wrist is intact.
Right.
Okay,
Uh,
so
That is also a low radial nerve palsy, you can call it.
thank you very much, Warid. I think that brings us to the end of the questions, and thank you, and hopefully we'll see you again in some future meeting.
Thank you so much, sir. Thank you so much. It was pleasure to be here.
Great, thanks a lot.
yeah.
Thank-
Thanks, sir. Thanks,
So
Warid.
there's one last
It's
question
great.
about trigger
Yeah,
finger examination. Okay,
Oh,
trigger finger. Okay. All right.
it was
So
getting obvious at the end.
again, yeah, I think I've not talked about it, but yeah, trigger finger is again a very important clinical. I am somehow I like to diagnose most of these things clinically because see again, X-ray and MRI will not tell you about trigger. So palpation of the A1 pulleys is very important. See, most of the time patient will tell you problem तो इधर है क्योंकि ये lock हो रहा है PIP joint. But the problem is actually in the palm when where the flexor tendon gets locked in the PIP. So this crease always palpate, and that patient will definitely have tenderness, and they will go to they will be like, yeah, यहाँ पे ही problem है. So palpation of the A1 pulley, of course, it's a clinical diagnosis. Patient most of the time will tell you there is snapping. I'm not able to extend the fingers; it gets locked. I have to use the other hand, and in the morning it is more. And in later stages, they when there's a synovitis, they are not able to flex then because it becomes bulky and the tendon doesn't pass through the pulley. So they are stuck. Initially, it is able to flex, not able to extend, they snap, and later on, they is not able to flex. Same happens with the thumb also. So palpation around the distal palmar crease, which is the A1 pulley, and also for the thumb near the proximal crease, there is where you get the tenderness, and that is a pretty simpler way to diagnose it.
And you can usually feel a nodule there which is moving.
Yes,
And
absolutely. There's a
when it
nodule
extends, you can feel it
which is
snapping
tender.
to that area. Yeah. So that's very clear. Usually the diagnosis is very clear.
It's pretty clear. Yeah.
Okay, great. Thank you very much.
Thank you,
So
sir.
till
Okay,
next time.
thanks, Janki. Thank you,
Bye,
sir.
everybody. Bye.
Bye.
Right.